In this disease, there are granulomas and enlarged lymph nodes. Always diagnosis is a confusion. What is this confusing lung disease called as, students? It is called as sarcoidosis. Let us discuss regarding sarcoidosis. Sarcoidosis is a multi-system disorder. Sarcoidosis is a multi-system disorder. It is a multi-system disorder with non-caseating granulomas. It is a multi-system disorder with non-caseating granulomas. Coming to the etiology. These Americans feel this sarcoidosis is due to some autoimmune phenomena. Americans feel this sarcoidosis is due to some autoimmune phenomena. Japanese brought a theory about propionobacteria. We Indians always confuse this with Mycobacterium tuberculosis. On the whole, still the etiology is unclear. If somebody asks you what is the etiology of sarcoidosis, still it is unclear. If you cannot convince people, at least confuse them. This is the thing happening with sarcoidosis. Nobody knows exact etiology. Each and every country has a different theory. We have discussed it as a multi-system disorder. Now, what is the most common system involvement? Most common involvement will be pulmonary involvement. Most common involvement will be pulmonary involvement, and this pulmonary involvement is given by a staging called as scadding staging. It is given by a staging called as scadding staging. According to this, there are 4 stages. Stage 1, patient will have bilateral hilar lymph node enlargement. If you consider this is the lung, in this stage 1 there will be only lymph node enlargement. Then stage 2, there will be bilateral hilar lymph node enlargement. Along with that, few areas of lung infiltrates. This is how it appears. Consider this is the lung. There will be lymph node enlargement and few areas of lung infiltrates, preferably more in the upper zones. Then coming to stage 3. It will be only lung infiltrates. Stage 3, the patient will have only lung infiltrates. Now, these lung infiltrates can be throughout. Stage 3, it will be like this. If this is the lung, now there will be lung infiltrates throughout, more diffuse. Then stage 4, it is characterized by shrinking of the lung. It is characterized by fibrosis. So, small lungs. So, shrinking of the lungs, there will be fibrosis, small lungs. Because most common involvement is the pulmonary involvement. What will be the most common symptoms in sarcoidosis? It will be symptoms of respiratory system. So, most common symptoms will be cough, shortness of breath, because most commonly it is the lung getting involved. Patient presentation will be with which symptoms? Patient's presentation will be with the lung symptoms. Patient presentation will be with lung symptoms. Then coming to, in sarcoidosis, there are few visual characteristics called as phenotypes. What are the important phenotypes of sarcoidosis? First phenotype that you should know for your exam is lupus perineo. Lupus perineo. This is skin involvement in sarcoidosis. This is skin involvement in sarcoidosis. Where all the skin is involved? Skin is involved over bridge of nose. It is painful and nodular involvement, bridge of nose and area beneath eyes and cheeks. Area beneath eyes and cheeks. Then we have Lofgren syndrome. This patient will have erythema nodosum. This patient can have erythema nodosum, uveitis, arthritis, and hilar lymph node enlargement. These are the important components. Even though it is a multi-system involvement, these patients generally will have good prognosis. The next important phenotype is uveoparotid fever. It is also called as Hereford syndrome. As the name indicates, patient will have uveitis, parotiditis, fever, and most importantly 7th cranial nerve palsy. Frequently asked question. Most common cranial nerve involved in sarcoidosis. Your answer should be 7th cranial nerve. And you must be knowing what is lupus perineo, what is Lofgren syndrome, what is Hereford syndrome. These are all few phenotypes of sarcoidosis. Now you are having a patient with one of these feature. So you are having a patient with one of these feature. Now how will you assess the patient and decide on diagnosis? So write down investigations in sarcoidosis. Let us start with basic blood investigation such as CBC. In sarcoidosis there will be peripheral lymphopenia. What is the reason behind this? Due to sequestration of lymphocytes. Into lungs. Whenever sarcoidosis is happening, it commonly happens in the lung. Now how will your body fight against sarcoidosis? With help of lymphocytes. So what will your body do? It will divert majority of lymphocytes into your lung, because lymphocytes are going into the lung. Lymphocytes will be less in circulation. Because lymphocytes are less in circulation, there will be peripheral lymphopenia. Then we know that in sarcoidosis there is a granuloma. And this granuloma is capable of producing some substances. This granuloma can produce angiotensin converting enzyme that will be responsible for increased ACE levels, increased serum ACE levels in sarcoidosis. And this granuloma can increase a substance called as 1,2,5-dihydroxy vitamin D. Whenever vitamin D increases in your body, what will it do? It will reabsorb calcium. There will be hypercalcemia. This is the reason why in sarcoidosis there is elevated serum ACE levels and hypercalcemia. Then CT chest. CT chest will help me to know the pulmonary and mediastinal involvement, to see whether the lung is involved, mediastinal lymph nodes are getting involved. Pulmonary and mediastinal lymph node involvement can be seen. But in our country there is another common disease which has lung and mediastinum lymph node involvement. What is that? It is here TB. Now how do you differentiate a TB lymph node? How do you differentiate a TB lymph node versus sarcoid lymph node? So what happens in TB lymph node? What happens in sarcoid lymph node is the next concept. Now in TB lymph node, generally there is necrosis of the lymph node. Because of that necrosis, the central part will appear less dense because it has been necrosed. The peripheral part, even though it is normal, because central part is less dense, peripheral part can appear bit more dense. This phenomena is called as central hypodensity with peripheral rim enhancement. In TB lymph node there is central hypodensity. Why central area is a hypodense? Because of necrosis with peripheral rim enhancement, whereas in sarcoidosis there will be only single or uniform density. Next investigation is a bronchoscopy. In bronchoscopy, if you take the secretions, it is called bronchoalveolar lavage. If you take tissue, it is called bronchoscopic biopsy. And what will be the biopsy picture? You know, there will be non-caseating granulomas. And within the bronchoalveolar lavage, within the lung, what cells will be in excess? Lymphocytes. I told you there will be sequestration of lymphocytes into the lung. So you notice lymphocytosis. And if you keenly examine those lymphocytes, there will be increased CD4 by CD8 ratio. CD4 cells will be more when compared to CD8. This is a very important finding, increased CD4 by CD8 ratio. Then what is considered as investigation of choice? Write down this statement from Harrison. In a compatible clinical scenario, biopsy of involved organ showing non-caseating granulomas is conclusive for sarcoidosis. Most important in diagnosis of sarcoidosis is the clinical scenario. You should suspect this patient to have sarcoidosis, and you should have ruled out all other diseases with similar presentation. Now in your mind there is only sarcoidosis. Now you have done a biopsy, and that biopsy is showing non-caseating granulomas. That will be conclusive for sarcoidosis. Apart from this, there is an old test called as gallium scan, not done routinely nowadays. What is the principle? There will be increased uptake of gallium increased uptake of gallium by involved organs in sarcoidosis. Increased uptake of gallium by involved organs in sarcoidosis. So where all the gallium uptake happens, it can happen in the face. Where it will happen? Parotid and lacrimal glands. In the face, it will be taken up by parotid and lacrimal glands, whereas in the thorax, it will be taken up by mediastinal lymph nodes. It will be taken up by mediastinal lymph nodes. Because of that, what changes can happen? If you consider this as face of the patient, there is increased uptake by lacrimal glands, increased uptake by parotid glands, increased uptake by lacrimal glands, increased uptake by parotid glands, increased uptake by parotid glands. Now if you consider this is the nose of the patient, it is just looking like face of a panda bear. Sorry if it is not looking like that, it is looking like a alien. It is called as panda sign. It is called as panda sign. Now coming to mediastinal lymph node enlargements, let this be the trachea, let this be the bronchus. There can be increased uptake by paratracheal and bilateral hilar lymph node. Now because of this increased uptake, now if you join these structures, it can appear like a sign. What is this sign? This sign is called as lambda sign. This sign is called as lambda sign. There can be varying degrees of uptake by the mediastinal lymph node. Now if you join all this, it looks like a sign. This sign is called as lambda sign. Very important in gallium scan. In the face you see panda sign, in the chest you see lambda sign. Coming to the treatment of sarcoidosis. First thing what you should do is, what is the general condition of the patient? Is he asymptomatic? Is he asymptomatic or symptomatic? Is he asymptomatic or symptomatic? We are discussing the treatment of sarcoidosis. If the patient is asymptomatic, I should wait and watch, because sarcoidosis, you don't know why exactly it is happening. In few, it can have spontaneous resolution. I should wait and watch for any spontaneous resolution. I should wait and watch for any spontaneous resolution. Now if the patient is symptomatic, I should start treatment. Most important drug is steroid. This sarcoidosis is also some abnormal inflammatory response. To bring that abnormal inflammatory response, you should start steroid. Along with that, you can add methotrexate, hydroxychloroquine to modify the immune response. So all this have activity in modulating the immune response. Hydroxychloroquine. Point to remember here is, if the patient is asymptomatic, wait and watch for spontaneous resolution. If patient is symptomatic, most important treatment will be steroid. We don't know why exactly sarcoidosis is happening. In few, it can resolve by itself. Let us see some images related to sarcoidosis. This is the panda sign in the face and this is the lambda sign. You can see here, students, in the face, increased uptake by parotid lacrimal glands. You can see the classical panda sign, whereas in the chest, because of uptake by mediastinal lymph nodes, you can see this lambda sign. So, two important, we have panda sign, lambda sign, panda sign and lambda sign. Try to solve case number 25. 20-year-old female presents with dry cough and dyspnea. Chest X-ray has been performed and it demonstrates bilateral hilar lymph node enlargement with bilateral well-defined parenchymal nodules. All help in evaluation except. Now this is suggestive of sarcoidosis. So why is it so? Patient is having bilateral hilar lymph node enlargement with parenchymal nodules, not looking like an infection, sarcoidosis. All will be helpful in sarcoidosis except CT chest, yes, to see the exact mediastinal lymph node involvement and lung involvement. Serum ACE levels, yes. Gallium scan will also be helpful, but it is not CD4 by CD8 count in blood. It is in bronchoalveolar lavage, because in the blood the CD4 by CD8 count, no point in saying, because lymphocytes are less. Where are lymphocytes in excess? Lung. Within the bronchoalveolar lavage you should see this elevated CD4 by CD8 ratio. In this disease, this patient is an industrial worker. He is getting exposed to the particles of his occupation, later developing a lung disease. What is this called as? Occupational lung disease. Write down, students. Most common occupational disease, occupational lung disease worldwide. Most common occupational lung disease worldwide. Your answer should be silicosis. Most common occupational lung disease worldwide, your answer should be silicosis. Then if they ask you a question like this, what is the particle with maximum malignant potential? What is the particle with maximum malignant potential? The options generally they give is asbestos, silica, coal. The order of preference will be asbestos, silica, last in the list will be coal. Actually, the malignant potential of coal is not yet exactly known. We don't know whether coal can cause malignancy or not. Here in this slide we have understood most common occupational lung disease worldwide is silicosis, and particle with maximum malignant potential is asbestos. Maximum malignant potential is asbestos. For your exam they will ask you the differentiating features of silicosis, asbestosis, coal workers, pneumoconiosis. I have made this into a table for easy understanding. So write down the important differentiating features of asbestosis, silicosis, coal workers, pneumoconiosis. We will discuss in terms of what are the occupations responsible and what will be the important features. For asbestosis, occupations will be shipbuilders, construction workers, shipbuilders, construction workers. The important features of asbestos. Consider this is the lung. Let this be the lung. Comfortably resting on the diaphragm, and let this be the heart shadow. Whenever there is asbestos exposure, one can notice calcifications on the mediastinal and diaphragmatic pleura. Calcifications on the mediastinal and diaphragmatic pleura, calcifications on the mediastinal and diaphragmatic pleura. These calcifications on the mediastinal and diaphragmatic pleura are called as pleural plaques, and these pleural plaques are considered as most specific for asbestos exposure. These pleural plaques are considered as most specific for asbestos exposure. As time progresses, there can be formation of fluid. There can be formation of fluid within the pleural surface. Initially, this will be a benign pleural effusion, and still the exposure is continuing. These patients can develop fibrosis more in the lower zones. This is called as lower zone fibrosis. There can be a benign pleural effusion, and one can also notice fibrosis in the lower zones. Still the exposure is continuing. There will be chances of malignancy. There will be chances of malignancy. Now, what is most specific malignancy and what will be most common? Most specific will be mesothelioma, whereas most common will be still lung cancer. Point to remember here is smoking and asbestos exposure synergistic. Smoking and asbestos exposure synergistic in increasing lung cancer. It is like whenever somebody is actively smoking, smoking can damage the mucociliary mechanism. Because of that, when the patient is inhaling the asbestos, that asbestos particles will not go out from the body. Now already this asbestos particle is having high malignant potential. If it is permitted to stay in the lung, the chances of malignancy will be high. So smoking, what it is doing, it is damaging the mucociliary mechanism and it is permitting asbestos to stay in the body. That results in more chances of lung cancer. This is regarding asbestosis. Now coming to silicosis, occupations, sand blasters, stone crushers. Coming to the important features, consider this is the lung. Initially there will be upper zone individual areas of involvement. These upper zone individual areas of involvement, these are upper zone nodules. As time progresses, these nodules will merge into large areas of fibrosis. There is merging of nodules. This merging of nodules, it is called as progressive, massive fibrosis, also written as PMF. Whenever silica exposure continues, there can be development of infection in the upper zones of the lung. What is this infection that silica particles are responsible? Tuberculosis. Why is it so? Silica particles damage the alveolar macrophages, and alveolar macrophages are considered as first line of defense against TB bacilli. Then there is a very important feature associated with, silicosis. There will be bilateral hilar lymph node enlargement. There will be bilateral hilar lymph node enlargement, and within these lymph nodes one can see calcification more in the periphery. Bilateral hilar lymph node enlargement with calcification seen more in the periphery. This type of calcification is called as eggshell calcification. There is bilateral hilar lymph node enlargement with eggshell calcification. Now coming to coal workers pneumoconiosis. The occupation will be coal miners. Let us see the important features. Point to remember here is, initially the pathological features of silicosis and coal workers pneumoconiosis can be similar. Only difference is the exposure history. So here initially one can notice individual upper zone lesions. There can be individual upper zone lesions. This phenomena is called as simple coal workers pneumoconiosis. CWP means coal workers pneumoconiosis. As time progresses, these individual areas can merge into large areas of fibrosis. There can be merging of lesions. This phenomena is called as complicated coal workers pneumoconiosis, also in some books written as progressive massive fibrosis, because it is the same thing. In silicosis also individual areas merging, that merging was called as progressive massive fibrosis. Here also there is merging. So this merging in coal workers pneumoconiosis can also be called as progressive massive fibrosis in some books. And exposure to coal can result in COPD. And the lung cancer risk is not yet exactly known. We don't know exactly whether there can be lung cancer, yes or no. Whereas in silicosis, lung cancer can happen. There is evidence that silicosis can cause lung cancer. So this is again an important differentiation. So coal workers pneumoconiosis, the lung cancer risk is not known. So which has highest lung cancer? So this is very, very important. Out of these three, highest risk of lung cancer is asbestos. Lowest will be coal workers pneumoconiosis. Whenever I am discussing about coal workers pneumoconiosis, I should tell you a combination. What is that combination? It is Kaplan's syndrome. What is this Kaplan's syndrome? It is combination of rheumatoid arthritis with pneumoconiosis. Pneumoconiosis is nothing but occupational lung disease. And what are the particles responsible? It was first identified with coal. Nowadays it is happening more frequently with silica. So Kaplan syndrome is combination of rheumatoid arthritis and pneumoconiosis. Most common particle as of now is silica. It was first identified with coal exposure. Now if you see here, this table, asbestosis is predominantly a lower zone disease. You can see in asbestosis, the lower zones are predominantly involved, whereas silicosis is predominantly upper zone disease. Coal workers pneumoconiosis is also predominantly upper zone disease. Asbestosis lower zone, silicosis upper zone. Coal workers pneumoconiosis is also predominantly upper zone. So in the exam, if they ask you shipbuilder lower zone fibrosis, answer automatically asbestosis. A stone crusher, there is hilar lymph node enlargement with eggshell calcification. Your answer should be silicosis. a coal miner with pneumoconiosis, with respiratory symptoms and with rheumatoid arthritis. What should be your answer? Kaplan syndrome. Why is it so? Rheumatoid arthritis with pneumoconiosis. Question will be like this. A coal miner is now having shortness of breath and joint pains. Shortness of breath will correlate to pneumoconiosis. Shortness of breath will correlate to pneumoconiosis. Joint pains will correlate to rheumatoid arthritis. The combination Kaplan syndrome. Now what will be the treatment of these diseases? Once it has happened, these are irreversible. What we can do is we have to be very careful in preventing. Once it has occurred, the treatment is mainly supportive. Supportive in the sense, if patient is having an infection, we give antibiotics. If patient is having hypoxemia, we give oxygen. If possible, we refer to lung transplant. This is regarding the various occupational lung diseases.